Hello, welcome to this video which takes you through the process of providing a differential diagnosis for clients with a history of trauma. I'm Dr. Brazier. This presentation was informed by an article entitled DSM-5 Differential Diagnosis for Clients with a History of Trauma, 4 Steps to Accurate Diagnosis by Bloom. So by the end of this video, you're going to be able to understand a 4-step differential diagnosis process. You're going to be able to discover how a history of trauma impacts diagnosis, conduct a more effective clinical interview, and formulate a more comprehensive, accurate initial DSM-5 diagnosis. Psychological disorders are particularly difficult to diagnose because they lack a signal symptom. A signal symptom is like a single primary indicator of appropriate diagnosis, like a COVID-19 positive test, right? Instead, psychological disorders are like clusters of overlapping symptoms, and they're diagnosed based on the pattern of symptom occurrence. In the case of trauma, these overlapping symptoms can include ones related to arousal and reactivity, avoidance, intrusion, and negative cognitions and moods. So for diagnostic purposes, the DSM-5, the Diagnostic and Statistical Manual, can be used to get the criteria and diagnostic names. So the DSM-5 contains references for each disorder that includes cultural differences, gender differences, onset, prognosis, differential diagnosis, and comorbidity. The ICD, the International Classification of Diseases, created by the World Health Organization. So I believe that most of the world is now using the ICD-11 at the time that this video is being filmed, while the US is still using the ICD-10. The ICD is used worldwide to compile statistical information about various diagnoses, and it provides us with the codes. So it's important to note that these two are not identical. In other words, while there's a lot of overlap between them, you're going to find variation as well, and this can make things a little bit tricky. The DSM-5 disorders are patterns or syndromes of disturbance in a person's cognition, affect, emotion, behavior, and or their physiology. To properly diagnose a person, there are a whole set of steps that we have to take. We have to look at each of these steps in turn. So the first step is to notice the pattern or syndrome that is occurring. And then we have to discover whether the person meets criteria for a disorder. And we have to specify severity, and then we can add additional specifiers if appropriate. And then last but not least, we can select the appropriate ICD-10 code that corresponds with our diagnosis. So a complete DSM-5 diagnosis is like a list. It's not a single line unless only a single line fits. So here's an example of a complete diagnosis for a single client. F43.21 adjustment disorder with depressed mood. F10.20 alcohol use disorder, moderate. Irritable bowel syndrome as reported by client. So notice that the Z code, Z63.5, disruption of family by divorce, comes last. So it's estimated that 5% of U.S. adults who seek outpatient care each year experience a diagnostic error. The error rate in diagnosis in psychological disorders is not well documented, but it's speculated to be at least 10% each year. Errors in diagnosis of psychological disorders are reduced when we use a structured and intentional process. We ask the client to provide both paper, pencil / digital information as well as verbal information about symptoms, medical conditions, medications, drug use, and we use techniques to avoid known sources of error in each step of the diagnostic process, and we include like a differential diagnostic process. So I've reduced the steps in the diagnostic process down to 4 here. First, gather client information through any pre-interview materials and the clinical interview. Next, identify syndromes. Then formulate a differential diagnosis. And finally, formulate an initial DSM-5 diagnosis list. So let's use a case study to illuminate these steps in the diagnostic process. Here's the fictional case of Roger. So Roger is a 65-year-old African-American firefighter with a diagnosis of post-traumatic stress disorder, which developed after years of being a first responder. Roger was diagnosed with PTSD 4 years ago and responded well to treatment until recently. He retired 2 years ago after 30 years as a Chicago firefighter. Last week, his wife Betty insisted that he see a counselor. Betsy has come with him to the intake session. Betsy requested this appointment for counseling because, quote, Roger no longer listens to me and he's very forgetful. Okay, so our first step is to gather information about the client through the pre-interview materials and the clinical interview. Roger was asked to provide a list of all medications that he's currently taking, prescription and over-the-counter. He was asked to complete a symptom rating measure, the cross-cutting level 1 symptom measure. So you can find this in your DSM-5 manual, page 734 to 744, or you can find it online. It's free, and there are developmentally appropriate variations for it as well. During the clinical interview, we as clinicians have sort of two different goals that we have to be addressing simultaneously. First and foremost, we're working to build rapport. We're warm, we're caring, we take our time. We embody those core conditions of empathy, congruence, and unconditional positive regard. We're using our active listening skill set. We're reflecting, we're asking open-ended questions. But our second goal is to obtain information, and we need a balance of these two. If we lean too heavily on the rapport building side, we're not gathering enough information to provide an accurate diagnosis. But if we lean too heavily on the information gathering side, the client is going to lack trust in us. And we're not going to be setting ourselves up for a strong working relationship, which we know is foundational for success in counseling. So the clinical interview contains 3 phases: intense observation, seeking to understand the whole client, and focused exploration. So focused observation begins with 5 to 10 minutes of open inquiry of the client's concerns and situation and rapport building. So you got to begin with broad, open-ended questions like, what led up to your making the decision to meet with me? And if somebody else reached out for the client, you can include them in the question by saying something like, your grandmother made this appointment for you. What's been happening with you that caused her to want you to come see a counselor? Okay, and then you got to follow the client's lead and you got to reflect to build rapport. This is active listening at its best. Make broad observations of cognitions, affect, behavior, and physiology. Record what the client and any others report, as well as what you observe on a clinical assessment form. Okay, but I want to issue a caution here. We have the human capacity to immediately jump from an observation of behavior to a judgment. So for example, if the client is like frowning, we can jump to the assumption that the client's angry. But we must describe the client's behavior without imposing any judgment upon it at this stage. Just the facts, just what you're observing. Okay. So if you're watching this video, I want to invite you to practice phase 1 with Roger. Complete the 4-column assessment tool. Pause this video and resume it when you're ready to proceed. Okay, let's continue with this case study by hearing more about what's occurring with Roger. Okay, so when asked what concerns led him to see a counselor, Roger replied that he's feeling fine, and he only came to the appointment because Betsy insisted. According to Betsy, his nightmares and flashbacks have been getting progressively worse in the last few months. And then after further discussion, Roger admits the PTSD symptoms may be increasing. He knows he's having more nightmares, but he doesn't always remember them by the time he wakes up the next day. In addition, Betsy complains that Roger has stopped listening to her and has become forgetful, not remembering like phone messages or to feed the dog. Roger always managed payment of the family bills, but last week Betsy found a whole pile of like 3 months of unopened bills pushed into a drawer, many now overdue. Roger expressed frustration because he doesn't think anything has changed and he thinks that Betsy is like just nagging him all the time. Okay, so first let's look at cognitions. Roger's thought content is as follows. His belief is that overall he's feeling fine. To Roger, nothing has changed except more nightmares, but his wife is nagging him. but Roger's wife's belief is that his forgetfulness is actually increasing. So then now let's look at Roger's thought process. What we're observing is that Roger demonstrates coherent speech, goal-directed speech, potential denial, and limited self-awareness. Now let's focus on affect or feeling. Roger's verbal and nonverbal expression shows frustration with his wife. As far as emotional regulation goes, we can't really determine that just by the information that we have so far. Now let's focus on Roger's behavior. His reported behavior is that he hasn't paid the bills for 3 months. His wife says that he doesn't listen. He forgot to feed the dog, and he has a history of exposure to trauma and PTSD treatment. Observed behavior, we haven't really observed anything noteworthy as of yet. Okay, finally, let's focus on physiology. So far, there aren't any physiological symptoms being either reported or observed. At this stage, we have reached a decision point. If you decide that the client is able to present themselves accurately, go ahead and proceed to phase 2. But if you decide that the client is unable to present themselves accurately due to possible impaired thinking or impaired communication, unusual experiences or beliefs, or heightened affect, you have to attend to this before you progress to phase 2. You may elect to conduct a mental status exam before proceeding further. So a formal mental status exam is off-putting to an intact client, and that can disrupt the rapport building. However, if we can't rely on the client to provide accurate info, we can't move forward toward an appropriate diagnosis. And by the way, if the client is 65 years or older, it's recommended that a mental status exam be conducted at some point to determine if there's mild cognitive decline. However, you don't have to do this right away unless you suspect that the info that the client is providing cannot be trusted. So then what should we do with Roger? Since he's over age 65 and memory concerns have been specifically broached, we should conduct a mental status examination right now. Next, we conduct phase 2 of the clinical interview, in which we seek to understand the whole client. So we take a complete history. That's going to take about 30 minutes. We assess for the history of the presenting concern or concerns. We assess for personal development, social background. We assess for previous mental health history. We assess for physical symptoms and medical conditions. We assess for family history, for medications, ones that they are prescribed, or ones that are over the counter that they're taking, and other substances, including alcohol, tobacco, illicit drug use. And you're going to record all these findings that you're gathering on that clinical assessment form. Another word of caution here. We have to be aware of potential cultural bias, which can lead to clinical misinterpretations of data. Think through, what is Roger's cultural makeup based on what we know so far? And then think, what is my own cultural makeup? And how might those differences lead to misinterpretations? We can incorporate the DSM-5 cultural formulation interview on page 752 to 757 into the clinical interview. So the cultural formulation interview is a series of questions or prompts that explores the client's cultural definition of the problem and perceptions of the cause, the context, support of the problem, stressors, supports, and the role of cultural identity for them. Okay, now take a pause and consider. What common symptoms for syndromes in the DSM-5 have not been discussed yet by the client? You need to review with the client any responses on that DSM-5 cross-cutting symptom measure that have not been disclosed in the interview. Compare the two. Ask about DSM-5 symptoms for syndrome areas that haven't been covered so far. So, for example, have you been having any unusual thoughts or rituals? Clients might refrain from broaching information that they feel embarrassed about, like sexual dysfunction, abuse history, etc. However, we've got to attempt to uncover at a surface level any information that could help us make an appropriate diagnosis. So review with the client any noticed discrepancies between those info sources, and speak with a family member or other informant if you need, but you got to make sure to get a release of information to do that. Best case scenario, the client is present for this discussion with the informant so that there's no potential for mistrust to build. And then in the interview, only when you believe you have enough information to begin sorting the signs and symptoms into patterns or syndromes. Okay, more information that we're going to gather from Roger through this focused exploration. Over time, Roger's repeated exposure to and witnessing of the destruction of fires and human death led to classic PTSD symptoms. Betsy and Roger agree that until the last few months, his symptoms have been well managed. He attended group sessions sponsored by the Firefighters Union for 2 years and continues to take Celexa and SSRI for anxiety. He also takes hydrochlorothiazide, thiazide diuretic for high blood pressure. He sees a nurse practitioner every 4 months for medication checks. He states that he only drinks on rare social occasions and he denies drug use. Roger appears physically fit and he reports going to the gym twice per week. The couple was always socially active with friends in their church. Betsy complains that now, though, Roger is reluctant to go out. He just stays home and watches TV. Throughout this interview, Roger shows little emotion in his face or in his body. We're going to need to add this information to the clinical assessment form, right? All this information. So here we go. Cognitions. Thought content, same. Thought process, same. Nothing new there. Affect. Prescribed Celexa for anxiety, and little emotion expressed. Behavior. PTSD treatment, decreased social activities, goes to the gym twice per week. And then physiology. Physically fit for his age, prescribed a thiazide diuretic for blood pressure. Okay, so now we finally arrived at step 2, identify syndromes. Yeah, so we got to consider patterns across the clinical assessment form, cross-cutting symptom measure, and the client's developmental, psychosocial, and psychological history. So this requires knowledge of key symptoms for each class of psychological disorder. This step ends when you have identified all the syndromes that seem to be present. Syndromes aren't diagnoses. They're like broad categories. They're clusters of symptoms. So I want to go ahead and invite you to pause the video here and identify syndromes and resume it only when you are ready to proceed. Okay, first we see a trauma-related syndrome. Roger has a history of exposure to trauma, previous diagnosis and treatment of PTSD, nightmares, flashbacks, and anxiety. We're not yet certain whether the anxiety symptom is best explained by the PTSD alone or whether it might demand its own syndrome to be explored. Another syndrome at play here is one related to cognitive decline. Roger's forgetful, with memory decline, lack of self-awareness, decreased social activity, lack of attention. And then, additionally, there may be a third depression-related syndrome. We know that frustration can be an indicator of depression in some men, and the poor concentration and the decreased social activities also cluster underneath a depression-related syndrome. So we're going to need to take a deeper look at that one. And yet another caution to be aware of. Allowing a prior diagnosis to shape or limit your identification of other patterns that are present is a factor. So Roger carries a diagnosis of PTSD, and it'll be easy for us to let that sort of shape us. The client reports, I have PTSD flashbacks all the time. So we have to watch out for confirmation bias. As humans, we can tend to look for evidence to confirm what we already believe, and that makes us ignore evidence that disconfirms what we already believe. So, for example, a client previously diagnosed with panic disorder described to her doctor that she has been having panic attacks or anxiety attacks, and that doctor then fails to determine whether these actually fit criteria for panic attacks. So always conduct your own complete assessment so that you have a complete set of data, and prepare an assessment worksheet to organize information and to help you identify patterns. So now we've arrived at step 3, formulate a differential diagnosis. A differential diagnosis is a list of all possible diagnoses with criteria symptom sets that include one or more of the client's symptoms. When generating a list of potential diagnoses, it can be helpful to follow the Othmer rule of 5. So what are 5 diagnoses that might fit? We can usually come up with a couple of potential diagnoses without thinking much about it, but having to come up with 5 forces us to expand our thinking. Consider medical conditions that could cause the symptoms or that could exacerbate those symptoms that you're seeing. And consider the use of medications, obviously, again, both prescription or over-the-counter, as potential sources of symptoms as well. Don't forget that one. And then consider the use of substances, alcohol, tobacco, illicit drugs, as potential sources of symptoms. And consult the DSM-5 manual for differential diagnosis information for each psychological disorder. These are listed in order of probability, and that hack that the DSM-5 provides can be helpful. So here's a differential diagnosis list for Roger. All of these include one or more of Roger's identified symptoms in the criteria list. Post-traumatic stress disorder, medication-induced depressive disorder, mild neurocognitive disorder, formerly known as dementia, adjustment disorder with mixed anxiety and depressed mood, depressive disorder due to another medical condition. There's our list of 5. Now we have to narrow down the list by reducing from what is possible to a smaller list of what's more probable. So remove any diagnoses whose full DSM-5 criteria are not being met at this time. The DSM-5 Handbook of Differential Diagnoses provides decision trees and comparison tables for differential diagnosis when a symptom is shared by many psychological disorders. So like, for example, aggressive behavior is one, psychomotor retardation is one, hallucinations is one. So this is also available as an app for the iPhone or iPad. Let's begin with the PTSD since it was previously diagnosed and Roger meets multiple criteria based on what we know so far. When the client presents with a history of trauma, we must assess the nature of the trauma experienced. For diagnostic purposes, we have to adhere to the DSM-5 definition of a traumatic event in which the person experienced or witnessed an event when they or someone they saw were seriously injured, or they thought their life was in danger, or they thought they were going to be seriously injured or endangered. Now, the other option is severe psychosocial neglect prior to age 2. And the symptoms have to have developed only after the traumatic event, not before. We have to be able to confirm this or we can't give this diagnosis. For diagnostic purposes, we have to ask ourselves whether the traumatic event or events the client is describing meet DSM-5 criteria for PTSD. Psychosocial stressors are important in the pathogenesis of all DSM-5 disorders, but the DSM-5 has adopted a very strict criteria for what does and does not constitute a traumatic event where trauma and stressor-related disorders are concerned. Okay, so take a look at this handy-dandy table. Which of these does Roger have? Pause your video, identify which symptoms you see for Roger, and unpause it when you have your list. Okay, so for intrusion, which there must be at least one, Roger has 2, recurrent intrusive memories and nightmares. For avoidance, which there has to be at least one, Roger has trauma-related thoughts and feelings that he does not want to discuss. We saw that in the interview. For arousal/reactivity, which there has to be at least 2, Roger does have 2, irritability and aggression and poor concentration. For cognition/mood, which there have to be at least 2, Roger has 2, detachment and constricted affect. So does Roger meet criteria for PTSD? Yes. Yes, he does. So then we're crossing that one off. Next, let's look at the adjustment, or we check it out. Next, let's look at the adjustment disorder. Since Roger meets full criteria for PTSD, and he's already been diagnosed with it by us, we can eliminate adjustment disorder because one of the criteria for adjustment disorder is that the client's symptoms can't be better explained by a different disorder. So we're going to cross that one off. We check PTSD, we cross off adjustment disorder. Then what about the mild neurocognitive disorder? We need formal cognitive testing from a neuropsychologist and a formal medical diagnosis from a doctor for this disorder. So we got to refer him to these professionals. We'll put a question mark by that one for now until we get the results from the neuropsychologist and the doctor. What about the medication-induced depressive disorder? Well, in order to determine if that fits, we need to find out two things. Number one, do any of the medications that Roger is currently taking have known depressive side effects? And number two, when did his depression symptoms begin, prior to starting the medication or only after beginning to take it? So we probably don't know the answer to the question about interactions and side effects off the top of our heads. At least I don't know. We have to do some research. So we'll put a question mark beside that one as well for now. Finally, what about the depressive disorder due to another medical condition? We have to know if Roger has any medical conditions that might be causing the depressive symptoms. We need to refer him to a doctor for that one as well. So that's our third question mark. And we'll be waiting to hear back from the doctor before we can eliminate or accept this diagnosis. Okay, so now we've gone all the way through to the last step of this process. Formulate an initial DSM-5 diagnosis list. Almost there, y'all. So since we need more data to rule out some of the potential disorders on our list, we're going to need to refer Roger, and we're going to need to provide a provisional diagnosis only for those. For now, we're going to be sure to assign the correct DSM-5 name with the applicable specifiers, and we'll assign the proper ICD code that relates to it. Okay, so here's our formalized initial diagnosis list for Roger. F43.10, post-traumatic stress disorder, mild. G31.84, mild neurocognitive disorder, provisional. Hypertension reported by client. Rule out medication-induced depressive disorder, and then also rule out depressive disorder due to another medical condition. Okay, and then what happened next? So after the intake interview, Roger was referred for medical and further psychological evaluations. His physical examination did not reveal any medical problems other than high blood pressure, really. His prescribed medications, hydrochlorothiazide, a thiazide diuretic, and Celexa, an SSRI, are not known to cause depressive symptoms. Neuropsychological testing revealed modest impairment deficits in complex attention, memory, and social cognition. The neurologist diagnosed Roger with neurocognitive disorder due to Alzheimer's disease. Okay, so now here is our adjusted diagnosis list for Roger. G31.84, mild neurocognitive disorder due to Alzheimer's disease, moderate, without behavioral disturbance. F43.10, post-traumatic stress disorder, mild. And hypertension diagnosed by doctor. So now we have narrowed it down to this adjusted list. Okay, as we wrap up this video presentation, I'm wondering what you learned and also what you'd still like to know about crafting a differential diagnosis for a client with a history of trauma. But for now, I just want to thank you for your attention to this presentation. So here is the reference for the article from which most of this presentation was drawn, and I want to thank you.